Welcome, everyone, and thank you so much for joining us this afternoon for a very important conversation on maternal mental health support programs and solutions to overcome stigma. My name is Paige Bellenbaum. I am a licensed clinical social worker and a perinatal mental health specialist, and it is a true honor to be the moderator of this exceptional panel discussion. Before we get started with today's event, we'd like to share a message from the New York State Office of Mental Health Commissioner, Dr. Ann Sullivan.
Hi, I'm Dr. Ann Sullivan, your Commissioner for the New York State Office of Mental Health, and it's my pleasure today to welcome you to the roundtable discussion on maternal mental health and reducing stigma. We're working today in partnership with Mental Health News Education to bring you this roundtable discussion. We're very excited that you're all joining us here today because the issue of maternal mental health is so serious. We all know that 1 in 5 women during the prenatal and postnatal period have significant anxiety and mood disorders. We also know that a large number do not receive the treatment that they need. So how do we make a difference? The first thing we need to do is put best practices into our healthcare system. Practices such as screening women for depression and anxiety disorders before their baby is born, and then for at least up to a year or 2 afterwards, because we know that postpartum depression can come 6 months to a year or even longer after the birth of the baby. We also need to pay a lot of attention to stigma, because one of the biggest issues is still that women are not comfortable with admitting that perhaps they are anxious or depressed during pregnancy or after their baby is born. We need families to understand that this is a real condition that can be treated and that can make a big difference in the lives of the women and the babies that they are caring for. So maternal mental health is clearly a major priority. We know the terrible statistics that show that mortality during pregnancy is higher for Black women than for white women, actually 5 times higher. That means that as we design our services, we have to be sure that we are there to work for every community, and especially those communities at higher risk for maternal depression and maternal morbidity. We have done a lot of work to increase the ability for our professionals throughout our system to get the help they need in working with moms who may be depressed. Something called Project Teach that we put in place to have specialists available for anyone working with a pregnant mom or with a mom after the baby is born to be able to call and get assistance if they have any questions at all about what might be helpful for the women they are working with. So Project Teach, please call if you need to. We also have a trauma-informed network that can help with tons of resources for practitioners across the system to know how to work with moms in need. So please use our resources, but also tell us what else we need to do. That's what the roundtable discussion is all about. So again, thank you for coming today. And I know that the ideas and concerns and suggestions that you're bringing forward will help us all to serve better our moms and our youth.
Hello, everyone. I'm Dr. Karen Wagner. I'm a clinical psychologist, and I also lead the OMH Strategic Plan for Mental Health Stigma. So good afternoon, everyone. I'm so glad you're here. I just wanted to go over some important information regarding continuing education for social work and psychology. So there will be 2.5 CEUs, but you must attend the entire session all the way to the end, including Q&A. The roundtable will be recorded, and the recording and the slides will be made available for everyone to view and download after the session. Use the Q&A window for all of your questions, if you please would do that. Paige and another team will be monitoring these questions through Q&A, and that way Paige will be able to address as many questions as possible during the session. The chat is open. That's for networking and brief comments, around what's being discussed. So the chat is open during the discussion, but that's not required, of course, for CEUs. Feel free to click the X on the chat window if it's distracting and you want to close that. Okay, so questions in the Q&A, please. If you're experiencing any difficulties, please send a direct message to Isabella Hugh in the chat box. She will be triaging any kind of technical issues. And then for CEUs, a survey will be emailed to you after the event. Later today or tomorrow, you must complete the survey by November 27th to get CEUs. I do ask that all attendees, if you have the time, please complete the survey, because we ask, what were the strengths and how we might improve the roundtable discussion. So I'd like everyone to fill out the survey. There's a question if you want CEUs, yes or no, but it's required for those CEUs that you complete that survey. And then please wait 1 or 2 months after the event to get your certificate. It will be emailed to you. Okay. And any questions, you can email me. That might be on the next slide. These are the continuing education statements that are required when we provide CEUs. New York State Education Department, State Board of Psychology has approved OMH as a provider, and we have a 0122 approval number. And then the Office of Mental Health has also been approved to provide CEUs for social work 0227 to be a provider for continuing education. And then the next slide, I think there's one more. We have Roundtable 1, which happened last week, understanding maternal mental health and stigma associated with that. And the recording, the deck, and the speaker bios are all packaged in the same area and Behavioral Health News site. There's the link. So I think that covers, it's very, very important. I'm reminded, getting those certificates out to all the psychologists and social workers. Please attend for the full duration to get those CEUs. Thanks so much. Thanks for being here. And Paige, take it away.
Thank you, Dr. Wagner. And thank you again all for being here today. New and expecting mothers and birthing people across New York are suffering. 1 in 5 pregnant and postpartum people experience a perinatal mental health condition, including depression and/or anxiety, as we heard from our commissioner. And 75% of women and perinatal people impacted by these conditions remain untreated, increasing the risk of long-term negative impacts on mothers, babies, and families. The cost of untreated perinatal mental health conditions in the US is a staggering $14.3 billion annually. And here in New York State, the estimated cost of untreated illness is $598 million annually. Perinatal mental health conditions are the #1 complication associated with childbirth and tragically a leading cause of maternal mortality in this country. In fact, the latest New York State maternal mortality report found that mental health conditions were consistently a leading cause of pregnancy-related deaths each year from 2018 to 2021, and that 100% of pregnancy-related deaths due to mental health conditions were determined to be preventable. In response to these startling statistics, Governor Hochul recently announced New York State's first ever report on maternal mental health, led by the New York State Office of Mental Health and drafted by the Maternal Mental Health Work Group. This landmark report provides a detailed roadmap to improve the mental health of pregnant and postpartum women and birthing people across the state of New York. In conjunction with the report, today's event is the second of a 2-part maternal mental health stigma reduction roundtable discussion series. In part 1, last Thursday, we had an incredible lineup of panelists. They were discussing the signs, symptoms, and prevalence of perinatal mental health, the role that stigma plays as a primary barrier to accessing support and treatment, the ways in which research, innovative treatment models, trauma-informed care, and the lived experience can all inform practice and improve outcomes for pregnant and postpartum people. Today, we're going to learn about the continuum of care in maternal mental health, what programs are available in New York State to support and treat pregnant and postpartum people experiencing mental illness, and effective strategies to reduce stigma. If you missed last week's panel discussion, don't worry. There's a video recording as mentioned, and David is also going to put it in the chat if you'd like to watch it at a later date. It is now my great honor to introduce to you our esteemed panelist. Dr. Uju Berry is the Director of New York City Health and Hospitals Domestic Violence Mental Health Initiatives and Clinical Associate Professor at the Department of Child and Adolescent Psychiatry at NYU. Anna Red Fox, tribal citizen of the Shinnecock Nation and founder of Wutaminiho Birthwork, a full-spectrum Indigenous birth worker and Indigenous lactation consultant. Sonia Murdoch, Executive Director and co-founder of the Postpartum Resource Center of New York. Darian Raven Rickerson, the Program Manager of the Patient-Centered Outcomes Research Institute Maternal Health Equity Study at Public Health Solutions. And Dr. Ellen Turtellow, Associate Professor Emeritus of the University of Rochester Medical Center. Before we launch into questions for today, which I know you're all eager to have answered, I'd like to invite everyone who's in the audience to join us in a very quick poll that will give us a better sense of everyone who is joined today. So if you could take a minute to identify your primary professional role. And then what we'll do is we'll share results to the poll towards the end of today's conversation. And we're just going to ask you to participate in one more poll towards the end as well. Sonia, it is wonderful to have you here today. As the Executive Director of the Postpartum Resource Center of New York and someone who knows extensively about the supports and services that are available to perinatal people here in New York State, can you kick us off by painting a picture for our audience of the perinatal mental health continuum of care? And then after you've done that, we'd love for you to tell us about the Postpartum Resource Center and everything that you have to offer perinatal families.
Sure. Thanks so much, Paige, for this warm welcome. Also, I'm grateful to the New York State Office of Mental Health, Behavioral Health News, the other panelists here today, and everyone who's joining us for this opportunity. And so beginning with the continuum of care for maternal mental health, we go from prevention, support for mild symptoms, moderate symptoms, severe symptoms. Within each of these categories, I will share support programs that further help to strengthen the New York State landscape for parents when it comes to their mental health. So also, I do want to highlight the report that Paige mentioned, the New York State Maternal Mental Health Report. And on page 102, many of these resources are highlighted in the report. So for prevention, public awareness of perinatal mental health conditions, as well as emergency resources such as hotlines, are very important first step to decrease stigma. It's very important for everybody here today to be aware of the National Maternal Mental Health Hotline, as well as 988, the Suicide Crisis Lifeline. Moving forward, public awareness campaigns, again, very important to break through stigma. And with public awareness campaigns, New York State has examples through social media campaigns that they have implemented on social media. Also, the CDC has the Hear Her campaign, which does have a component for maternal mental health. An example on the county level is the Nassau County Perinatal Services Network's Maternal Mental Health Work Group, with their You Are Not Alone campaign, and with the Postpartum Resource Center's Ask the Question campaign. With psychoeducation, to gain training and education first before sharing with others and to learn further about models of care, as was mentioned by Commissioner Sullivan, Project Teach. Project Teach is a key resource for New York State. There are also resources for training, such as Postpartum Support International, Helping Hand Psychotherapy, the Motherhood Center of New York, the Selene Institute, as well as from today's panelists about especially collaborative care. to name just a few. Within psychoeducation, to consider the area of preconception counseling for prevention for those with a personal or family history of a mental health condition, to truly help someone for prevention planning with these possible parents, helping these possible parents of the future. From the United States Preventative Services Task Force, evidence-based preventative programs that we've been encouraged to further implement are the Mothers and Babies Program, the Reach Out, Stand Strong Essentials for New Mothers, also known as the ROSES Program, and the New York-based program, PrEP, Practical Resources for Effective Postpartum Parenting, led by Dr. Catherine Monk. Screening, which was covered in Roundtable 1 pretty extensively, and also sharing the main resource to learn again about screening and tools is Project Teach. Also a resource is the AIM Safety Bundles, including their bundles on perinatal mental health and perinatal patients and substance use disorder. When it comes to referral and resources, for social determinants of health concerns, there's the 24/7 service of New York State's Growing Up Healthy hotline. For referral and resources, there's Project Teach that offers trainings, education, as well as the Psychiatric Access Program, including a free consultation line. The Postpartum Resource Center of New York also offers resources and referral and support for parents, their families, and the community also. Moving into the mild symptoms, the resources include all of the panelists today and their support programs. For birth and postpartum support programs, to highlight the New York State Doula Initiative, doulas for prevention as well as support. Peer support programs and parental mental health peer support specialists are critical in the inclusion to include those with lived experience and recovery from perinatal mood disorders. And a recognized model is through the Postpartum Resource Center of New York. Support groups, hospital-based and community-based, and community health workers and home visitors with programs such as the Perinatal and Infant Community Health Collaboratives, pitch programs, nurse family partnerships, Healthy Steps, Healthy Start. For moderate symptoms, we move into more treatment possibilities. So the specialized perinatal treatment for individual couples, perinatal therapy, dyadic care, reproductive psychiatry for medication management. Examples in New York include Healthy Moms, Healthy Babies program at the New York State Office of Mental Health, operated clinic at Hutchings in Syracuse. Also, they include the Circle of Security group and the Maternal Depression Treatment Program through North Shore Child and Family Guidance Center in Nassau County. And the IOP, which stands for with Perinatal Intensive Outpatient Program, where the program offers meeting a few days a week for a few hours each time. The support program to highlight here is through the New York Child Center, the Child Center of New York's McCarry Perinatal Intensive Outpatient Program, an initiative of the New York State Office of Mental Health. For severe symptoms, there's the Perinatal Inpatient Hospitalization Program. We have the first program in the Northeast of the country with Zucker Hillside Hospital Northwell Health Program in Glen Oaks. A step-down program or prevention in some cases for inpatient care is the Perinatal Partial Hospitalization Program, PHP. The first standalone program in our state is offered through the Motherhood Center of New York, with the program offered virtually as well as in person in Manhattan. They meet every day for a full schedule with therapy, medication management, support groups, activities, and they could be meeting for a 2 to 3 week time period. So as we move forward from the continuum of care, I'd like to share about another way that further can be shared resources with patients, clients, and with patients and clients with the Postpartum Resource Center of New York. We call it the Take Care of You Action Plan, this Venn diagram, which then these resources can be shown very easily to consumers, patients, clients, their family members, and we look to always include medical resources, therapeutic, counseling resources, as well as social support, peer support resources. Thank you.
Thank you so much, Sonia, for that incredibly thorough overview of programs and services that are offered throughout the state of New York. I know that we're going to zero in and get a little bit more in detail with some of the programs that are presented here today, which I'm so excited to welcome and hear more about. It's such an important way to frame this conversation around the continuum of care concept, because I think so often in this space, there is sometimes a perspective that treating perinatal mental illness is a one-size-fits-all approach, and that anybody who's struggling will benefit from this type of service. Maybe just seeing a therapist, right, will be able to help reduce their symptom acuity. And when I talk about this continuum of care, I oftentimes liken it to a physical condition, right? So let's say somebody sprains their ankle versus has a fracture versus breaks their ankle. When we're talking about a physical health condition, there are different levels and step models of interventions in care that will help that individual heal from their injury. And so recognizing that there is this stepped care model in the mental health field as well, in particular with perinatal mental health, it helps us better understand when we're coming in contact with a pregnant or postpartum person who might be struggling with mental illness. This is somebody that would really require a higher level of care because their conditions are really interrupting their ability to care for themselves and or their baby. So I know that this person probably needs more than a support group once a week to be able to recover and feel like themselves again. So thank you for doing such a fabulous job describing everything from prevention all the way to high acuity, so that now our audience is aware of what those programs look like. And Sonia, not to put you on the spot, but while I have you here, and before I open this introduction and invitation to my other panelists, can you tell us a little bit more about the Postpartum Resource Center and everything that you all have to offer for pregnant and postpartum families?
Sure. And thank you, Paige, for describing the continuum of care, also comparing it to a physical condition. We know that further can help break the silence of stigma. So thank you very much for that example. We use that example also, and we find it very, very helpful. The Postpartum Resource Center of New York is a statewide nonprofit organization. I co-founded it in 1998 after supporting my sister through postpartum psychosis, severe postpartum depression, and did not want any other family in New York State to ever suffer like my sister, brother-in-law, and our families did from ignorance of ourselves as well as the medical community that we came across at the time. We provide free emotional peer support, educational information, healthcare support group resources. Our overall vision is called Project 62, 62 counties in New York State. We look forward to partnering with collaborators to further strengthen what we call the parental mental health safety net in that county, each county. And we have a toll-free statewide helpline, which is 7 days a week, 9 a.m. to 5 p.m. It's English, Spanish, as well as we utilize language line for other languages. We do have an online request help form. We have websites, English as well as Spanish website. We also have a statewide resource directory of quality resources for perinatal mental health, where people have completed an application. We have a vetting process, based on perinatal mental health training. We also offer many free virtual support groups. Some of the groups that I'll highlight here are our MERGE program for Black birthing persons and moms. Also, we provide support for fathers and also Spanish-speaking moms group. We also have our training institute, and we work with many community partners, healthcare providers, where we have a 2-day training. We also work and provide workshops in service training, doula training, as well as trainings on our support group programs, including our Circle of Caring support group program and the Next Step, Navigating the Fourth Trimester. We also do have a learning collaborative, which we also offer the Moving On Maternal Depression webinar series. And we also have a very active community of advocates, supporters through what we call the Voices Work Group. And those are people with lived experience who are further helping make a difference all throughout the state. So thank you.
Thank you, Sonia. And I just want to highlight one more time the value of the directory, where individuals and or providers can go in and identify all of the different programs, services, and individuals that provide perinatal mental health support throughout the state. So thank you for all the hard work that goes into keeping that directory updated and all of the other vital services that you provide to new and expecting parents. Dr. Berry, I would love to move over to you. And I just want to say you bring such unique insight to the perinatal mental health space. For those of us that are familiar with this particular area, we know that there are a lot of other elements and conditions that can intersect with perinatal mental health, substance use being one of them. We also know that as we start to look at research more and differently, that along with perinatal mental health being a primary contributing factor to maternal death and SUD, that in several places throughout the country, homicide also plays a critical role in maternal mortality. And that has everything to do with interpersonal violence. And you bring this insight in the work that you do in research and service delivery around the intersection of IPV and perinatal mental health. And I'd love to invite you to tell us all more about the important work that you're doing in this space.
Yes, well, thank you so much, Paige, and thank you also to my panelists. I look forward to hearing more about the work that you guys are doing. And everything you just said and outlined, Paige, is exactly it, and why I'm so passionate about this field. In addition to my role as medical director for New York City Health and Hospitals Domestic and Gender-Based Violence Mental Health Initiatives, I'm also a child psychiatrist and a women's mental health psychiatrist. I work in that continuum space that we're talking about right now, and I firmly believe in the power of the continuum. Especially because many of our patients and our families go through multiple different stages of their lives. And we know at each single stage, there are handoffs. And those handoffs, those gaps to the next person, to the next clinic, to the next department are opportunities where there are these transition moments where these families can fall through the cracks, become missed or become disengaged or just not followed. And so these are the crucial moments that we want, that our families are counting on us to be able to overcome and see and be able to provide these opportunities, that there are no more gaps and people don't fall through cracks, and to truly step up and provide. And one of the things I love about this continuum care model is that there are important dimensions, as you mentioned, the acuity that we see, also the places that people are provided, and the timeline. One of the things that our program with the DV, Gender-Based Violence Mental Health Initiatives, is really focus on where can care be provided. And where can families who are most vulnerable get that type of care in situations where they feel safe and they feel comfortable? And so one of the big aspects of why this is so important is that when we think about intimate partner violence and gender-based violence, it really kind of intersects and highlights just disparities and marginalizations and lack of resources and lack of opportunities and access to care. And one of the things you highlight so well is just when we think about intimate partner violence and domestic violence, it really is one of the biggest risk factors for postpartum mood and postpartum mood and anxiety disorders. Now, when I talk about domestic and gender-based violence, I just want to couch it in with some definitions of how we conceptualize intimate partner violence and gender and domestic-based violence. We think of DV as an umbrella term that uncovers IPV, that covers gender-based violence, sexual assault, sexual trafficking. And really, when people think about domestic violence, they usually think about it as just physical violence, such as hitting or strangulation. But I also want us to take us a step further and recognize that intimate partner violence and gender-based violence can also include financial violence and financial abuse and control. Really, what that looks like is that some families and some patients may not have access to their money or have control over their lives in terms of how they want to deliver financially, how they want to think about what they want to do with it. We can also think about emotional abuse, and this becomes so important when we think about the intersection between early childhood mental health and maternal mental health. That oftentimes survivors will say that their abusers will use their kids against them, emotionally say, "You are a bad mom, and you're never going to be a good enough mom," which again leads to more stigma, is what we're going to be talking about and addressing more during this panel. They can also use structural discrimination against them. So using systems, so threatening to call ICE or threatening to call the police and escalating police brutality. And in particular within gender-based violence, we also know that IPV can lead to reproductive coercion, where families and patients aren't able to control their reproductive rights or be able to control when they want to have children or have access to birth control, and so much more. And then we understand that intimate partner violence has many, many antecedents. In particular, the number one cause, as you've highlighted so clearly, Paige, is that the number one cause for pregnancy is actually homicides. And when we take a deeper dive into that, the number of reasons for homicides is exposure to intimate partner violence. In addition, when we think about perinatal mood and anxiety disorders, we also know that suicides and overdose deaths with SUD are also leading causes of death during this time period. And again, when you take a deeper dive, the risk factors for suicide and overdose deaths is actually exposure to intimate partner violence. And then on top of that, so that's just the severity. On top of that, just thinking about the prevalence, 1 in 3 women and 1 in 5 men will be exposed to intimate partner violence and domestic violence in their lifetime. So it is so prevalent. And I know that I saw people putting in their job descriptions and where they work. As providers, you will see this. You will see intimate partner violence like every day, just because of the prevalence and the statistics. So it's really important for us to really think about breaking down stigma for us in terms of recognizing it, and that it covers and cuts across race, ethnicity, even socioeconomic status. Actually, just last week, I had a colleague who reached out because one of her medical residents was experiencing intimate partner violence in her household. So again, as providers and just thinking about stigma, we ourselves need to understand the rates in order to better help our clients understand how prevalent and how disabling this can be. But fortunately, as I just ran through all the statistics, fortunately, there are resources available for our clients and our survivors in New York City. And we are very fortunate to live in the city and also in the state that really kind of takes on this mantle to recognizing intimate and gender-based violence as a public health threat that needs public health solutions. So one of the programs I'm going to highlight today is a program I oversee, which combines 2 programs, the Family Justice Center program and the New York City Domestic Violence Shelter program. And it's run by New York City Health and Hospitals, which is the largest municipal hospital in the country. We serve over 1 million New Yorkers every year. Our tagline, which we just changed, says care for everyone, no exceptions. So we really do want to underscore that this is for everyone in New York City, that they can come to one of our 11 facilities and get immediate treatment, regardless of race, gender, ability to pay, or documentation status. It is for everyone. And what we recognize, again, with this continuum of care model and what New York City Health and Hospitals is trying to do is recognize that we can't just be in our bubble of the hospital system, that we need to bring some of our knowledge into the community. And that's where people may feel safe, in the community. And one of those areas is the Family Justice Centers. These are a one-stop shop for survivors of domestic and gender-based violence, where they can immediately get connected to a district attorney or to a family court, file an order of protection, get access to housing support, economic support. And then our program, for the first time in the country, provides on-site psychiatric and psychological care to those survivors free of charge. And then in addition, we also do a very similar embedded program in one of the 54 DV shelters in the city. DV shelters are shelters which are confidential, anonymous, they're scattered throughout all 5 boroughs. There are places for people to go where their home is no longer safe for them. And so they can go into one of these shelters and again, immediately get connected to advocacy services, economic services, and housing services. And then again, our program provides help for them on site. There are a series of psychiatrists, psychologists, and social workers providing individual therapy, group therapy, and medication management. And we do it very similar to what you talked about, Paige, and through this really tiered system. It's not a one size fits all. And so along with that, we also do extensive training to our staff to be able to provide these services for our clients in a way that meets their needs and meets the needs of their children. Because another piece too, when we think of that continuum, is that we think about pregnancy and postpartum. And once postpartum happens, there's a second individual that we also need to think of, which is that dyadic care that we think about, which is the parent and the child. We know through research when we support the parent's mental health, we support the mental health of the child. If we support the mental health of the child, we also support the mental health of the parent. They're just inextricably linked. You can't separate the two. And so we recognize that we really need to also think about that other family, the children, as much as possible. And especially in our DV shelters, where around 60% of the residents are actually children. And of those children, another 80% are under the age of 5. So that they're very vulnerable, and that link between parent and child is so crucial when we think about preventative measures as well. So I'm very, as you can tell, I could talk about this ad nauseum, and I might be getting the boot here, but there is wonderful resources that really helps our families really think about prevention, primary prevention, secondary prevention, and really kind of staving off the sequelae of postpartum anxiety disorders, and really thinking about DV and gender-based violence from a public health lens, and really thinking about how we can meet families where they feel safe in a co-located manner as well.
Thank you so much, Dr. Berry. That was wonderful, and so excited to hear from you in just a bit to speak more to the stigma piece that you mentioned. I want to move over to you, Anna. Such an honor and privilege to have you here. I know that you speak to your own work through the lens of lived experience, working specifically with an Indigenous community, and really providing yourself and your expertise as a resource to so many pregnant and postpartum people in need, through supporting them as a doula and also a lactation counselor. You do so many different things. Would love to invite you to speak to our audience and share with us more about your work as well.
Absolutely. Thank you, Paige. Wanikisuk, everyone. I am honored to be here today. I have been a full spectrum Indigenous birth worker for the past 6.5 years. I experienced a very traumatic birth with my first child. And I was essentially pushed into having a hospital birth that I kind of knew from the start that I really didn't want. And I was one of those statistics that you do see, but unfortunately, we are, as Indigenous people, really left out of the statistics. We are often underrepresented in a lot of the statistics. So that experience that I had actually pushed me into shifting my entire vision on birth and kind of taking that trauma that I experienced and creating something so, like another panelist mentioned, that is centered in community, and community is involved in all of the steps. I crowd fundraised and went to Canada to become a full spectrum Indigenous birth worker through an Indigenous owned and operated organization because I felt that I resonated with that more. I returned home and immediately started serving my community. I do serve all walks of life, but Indigenous and BIPOC people are my priority. Full spectrum allows me to cover any unique experience that a birthing person may experience, from pregnancy to postpartum, lactation support, abortion, miscarriage, stillbirth, anything grief and loss related. Um, and I also inspired someone to have a home birth here last year on Shinnecock, which was pretty amazing. When it came time to having my second child, I got a traditional midwife, and I had a Shinnecock doula, and we had a home birth here on territory. My partner and my family built an earth lodge, and we gave birth to our baby with our community, surrounded by community. And it was such an empowering and elevating experience given the first birth that I had. And so, being a birth worker, I have kind of realized that it's so much more than just birth, so much more than just pregnancy, and postpartum. And community really does play a role in that. And the structure of the reservation here that I reside on, we are often referred outside of territory, and all of our services, especially specialist services, are um, outsourced. We do not have prenatal care here. We do not have postpartum care. We don't have maternal health care, so you can get your annual exams. Um, Everything is outsourced. And so through my work, I have grown into being more of a full spectrum hub. We just trained 5 newly certified Indigenous lactation counselors. And so I'm trying to grow the network here on the reservation. I am one of 2 doulas, and that is all that we have here right now. So it's really about bringing in the community and educating the community, which is what a lot of my work is. When I first started as a doula, there was a misconception that I was a midwife and that I deliver babies, and it took me quite a bit of years to actually educate the community on my role and how I support birthing people and their families. Um, so with that, Watmineo means heartberry or strawberry in my language, and heartberries are very related to maternal body and women and just overall maternal energy. Um, I provide full spectrum birth support services, as I had mentioned. So I do follow families through pregnancy, birth, postpartum, lactation, and early parenting. And that also includes pregnancy release and pregnancy loss. I provide workshops and educational services. So these are community-centered workshops and educational sessions that cover various different topics. Like I mentioned, birth to me or birth work is not just centered on pregnancy to postpartum. Um, we cover body sovereignty, menstrual cycles, childbirth education, postpartum healing, and we also try to intertwine food sovereignty and so much more into the work that we do, because it's very important. And I also do offer speaking services. So I do like to share my expertise during panels such as today, and community talks and advocacy on maternal health and family health, particularly what it looks like for Indigenous communities, especially in Long Island and New York State. I also offer partnerships and collaborations. So I have had the pleasure of working with Sonia Murdoch of Postpartum Resource Center, and she initiated a 6-day intensive training of PMADs, and myself and another member of the tribe have gone through the entire 6-day training just to learn everything PMADs related. We started educating the community on PMADs as well, and just offering them another resource through the Postpartum Resource Center, because like I had mentioned, we really do not have special services here on territory. We also do provide tailored support circles that could look like anything birth related, anything feminine hygiene, feminine care. We're also looking to do perimenopause workshops as well, because I have come across quite a few people who in the community are looking for more ancestral traditional teachings on perimenopause. And we also do host workshops. So that looks like more hands-on workshops and learning about our bodies and learning about feminine hygiene care and how you take care of your body. And that's something that is not really spoken about. So to be able to offer that is a blessing to me. And I also do offer consultations for other tribal nations in across Turtle Island, across the United States, on guidance for initiating or strengthening their maternal health and family support services. There are a lot of nations that are like Shinnecock that are so behind in maternal health services and providing these services, especially PMADs, given all of the trauma that we have held on to for so long. There's so much that I could say on that, but uh, being able to offer this and provide trauma-informed care and just education is such a huge aspect of what's Mineo. And lastly, I am a recipient of the 2025 Dream Starter Grant, which is through Running Strong for American Indian Youth. And I have a grant project that is centered around developing and managing funding to support Shinnecock tribal members and our sister tribes in the Northeast region to access maternal health services, doula support services, midwifery care, and family health education and community programming. So right now, we are currently working on compiling a feminine hygiene and menstrual care product distribution that will be free to the community and our sister tribes. That also comes along with education, as I mentioned. And I am also working on a pilot program with a Black midwife here in Long Island. And she has offered to come to the territory one time a month. So that way she can offer her services here. Obviously, that would be covered through the grant, but that would allow our women to actually get the care that they need. I did do a survey, and there were a lot of disparities just within my own community and women not taking the measures to going to get their care done, their annuals or whatever, their um, pregnancy care, maternal health. They would rather just not go at all. So it's nice to bring someone into the community that is culturally understands what our structure of our community is like and kind of resonates with some of the issues that we deal with. And yeah, that's all. And like I said, I just want to say thank you all for having me here today. It is an honor.
And Anna, right back at you. It's an honor to have you here. And what an incredibly elaborate and amazing list of resources that you offer, that you've developed single-handedly, that you're able to offer to your community. And I always want to just highlight the power of lived experience and how it can be such an effective tool for change when we go through something like this and we understand it, how we can really harness that to make a difference in other people's lives, which is exactly what you're doing. So thank you. Thank everybody for your amazing work, and really interested in hearing more from you later on. Would love to move over to you, Darian. You are also doing some very interesting and exciting work at the Patient-Centered Outcomes for the Patient-Centered Outcomes Research Institute and Public Health Solutions. So please share with our audience members some of the perinatal health and mental health work that you're participating in right now.
Yes, yes. And please give me a thumbs up if my audio is good. Just
You're
want to
good.
make sure. Okay, thank you. So wow, thank you. And good afternoon, everyone. I feel super privileged to even just be here in this room and in this panel with all of these wonderful colleagues here. So thank you for inviting me and thank you for having me here. And I'm excited to talk through, a lot of the programs that I'm a part of. Um, so I'm going to start off probably at the macro level, just talking about what we offer at Public Health Solutions, kind of give a background about that very briefly, go into Family Connect, and then it funnels into, how the Impasse program makes sense. So as the largest public health nonprofit serving New York City, Public Health Solutions improves health outcomes um, and helps communities thrive by providing services directly to low-income families and bridging that gap that we have between healthcare and community service and community work. So our mission is to advance health equity throughout New York City. And we work to reduce the racial and ethnic disparities that we see in many of the social determinants of health that individuals and families experience. We serve nearly 100,000 low-income families each year at Public Health Solutions, with a concentration with working in communities where there's high prevalence of poverty and inequities in health outcomes, particularly amongst Black, Indigenous, and other communities of color in New York City. So our maternal child health unit, which is where Family Connect lives, serves over 1,300 families per year through our 7 home visiting programs, which provide support and education to pregnant and parenting families, with most of our programs located in Queens, particularly in Corona and Jamaica, where there's those particularly very high incidence and prevalence of maternal morbidity and mortality. In addition to providing a wide range of parenting education workshops, home visiting, our home visitors or our pregnancy and parenting navigators, they facilitate these connections to prenatal care. So that could be connecting our families to doula services, WIC, SNAP, breastfeeding support, access to baby supplies, safe sleep education, connections to health insurance companies, behavioral health services, mental health services, just to name a few. So Family Connect is more so kind of like an umbrella of multiple programs, initiatives, and prenatal and postpartum support groups that we provide. So within Family Connect, we have the Impasse program, which we launched on April 1st of this year with amazing success. So our Impasse program, it stands for the Enhanced Perinatal Mental Health Spectrum of Support. And thanks to a grant from Elevance Health, we were able to create this program because we've seen in the intersection of mental health and maternal health, and from both the social and clinical outcomes perspective, that no single program has kind of moved the needle in holistically and comprehensively addressing and improving perinatal mental health risk factors associated with maternal morbidity and mortality. So Impasse is a universal perinatal screening as well as a community resource network of mental health specialists, community organizations, all trained to support pregnant and postpartum people and families through a multifaceted and collaborative approach to increasing the access to our spectrum of support, which ranges from validated peer-based models, preventative approaches to mental health, clinical one-on-ones with group psychotherapy treatment, and additional inpatient and outpatient support for those experiencing those more serious mental health challenges, some that Sonia was introducing to us at the beginning of this panel. So some of the support groups that we run are the Circle of Caring and the Rose groups, which Sonia Murdoch has trained myself and many of our staff to facilitate at Public Health Solutions. We currently have had 2 full cycles of Circle of Caring and 1 full cycle of Rose at Public Health Solutions, ranging from English, Haitian Creole, um, Hindi and Urdu, and Spanish. And I may be blanking on other ones right now in the moment, but all of our groups are facilitated either in person or virtually or both, and in English and in multiple other languages. So in addition to these 2 groups, we also have Becoming Us, Birth Trauma Support, Time to Relax, and Círculo de Mamás. Those are all kind of community support groups for moms. We also have some social worker-led groups, which are Remembering You, Remembering Us, which is a perinatal bereavement group for families who have experienced an infant loss or fetal demise. We also have our Dad's Dialogue group, support group for fathers who are experiencing mental health challenges, experiencing symptoms of depression, and just want a cohort or community of other fathers that are going through the same experiences as them. So that is an evening group that we also offer in person at our Queens offices. We also have our Agape Family Therapy and Rising Ground provider partners. And those are our providers for one-on-one therapy sessions that we connect our families and individuals to. And we also have our connections with various hotlines and resource centers for our partners in crisis intervention. So that includes Postpartum Support International, or PSI, Postpartum Resource Center of New York with Sonia, and some of the other ones that we have listed here on the slides for crisis intervention. So with all that being said, Empaths, or the Empaths program, really exemplifies how we are incorporating that continuum of care that Sonia had introduced to us at the beginning of this session. So I know that was a mouthful, but I hope I was clear in describing some of the many programs. And I did not explain all of the programs that are here at PHS, but I'm more than happy to share via email any of those flyers for any of the support groups. Continuing the conversation in the chat, or even my email is here in the slides if there's any providers or organizations who have joined us here today who want to collaborate, become one of our service providers, or just to collaborate on workshops, educational material, anything like that, that we can continue getting these programs and workshops out to as many families who need it. So thank you.
Thank you, Darian. And what a wonderful example of the continuum of care, as you mentioned, right? Everything from prevention to psychoeducation to screening to treatment to referral to higher levels of care for pregnant and postpartum people who need it, and recognizing that that doesn't really exist yet, where we recognize in one place that it's not a one size fits all, and the fact that you're able to provide all of those different interventions depending on what are the individualized needs of that person. Thank you for that. And Dr. Turtolo, you have been waiting patiently, and we're so excited to hear from you. I just want to say before you begin, in last week's presentation and conversation, one of the things that came up and was very popular and there was a lot of interest in, and you're here to share much of with us today, is this collaborative care model. And we had Dr. Osborne, who at Weill Cornell, talking about her work in developing and rolling out a collaborative care program. And so we are really excited to hear you, as somebody who was kind of at the forefront of this in upstate New York, talk about your experience with that model and much more. So Dr. Turtello, take it away.
Okay, so I am going to talk to you about the collaborative care model that we put in place at the University of Rochester over the last 11 years. So this is a very, very short summary of a very long process, okay? So, but we can be a resource for providers, you know, healthcare workers, anybody who works in the space of perinatal care. So I joined the University of Rochester in 2014, and when I got there, I found, to my total surprise, that we had already had co-located psychological counseling in our office. We had 2 therapists. Many of you might know Dr. Ellen Polchuk. She was in charge of the program in our office, and she had 1 therapist and 1 student working with her when we started. So we got together and started talking about things. The first thing that we did was, so our providers our OB providers I'm an OBGYN, by the way. I don't know if you guys knew that or not, but our providers would refer through e-record to our psychologists in our office if somebody wanted counseling or needed counseling. So that's kind of where we started. And then in 2016, we reviewed the ACOG recommendations for screening. We were only screening at the postpartum visit for anxiety and depression using the Edinburgh tool. And so the new recommendations were to screen at the beginning of pregnancy. And at that time, it was not at 28 weeks, that came later. But we initiated screening at the beginning of pregnancy and then later at 28 weeks based on continuing to follow the updated recommendations. And at the beginning of pregnancy, we decided not only to screen for depression and anxiety, but also to screen for substance use and alcohol use, which is also an ACOG recommendation to screen everybody for alcohol use. We also changed the way we screened, which I think is really important. A lot of times in the postpartum visit screening, it was the provider just asking the questions off the Edinburgh screen directly to the patient, so the patient had to answer verbally. So we started doing paper screening, both at the new prenatal visit and postpartum, which they could do in like the waiting room. They were given the forms just as a routine basis, and they could do it in the waiting room while they were waiting to get checked in for their appointment. And then eventually we moved to tablet screening on iPads. And I think personally it decreased stigma because people would answer more honestly when they didn't have to directly talk to their provider and pretend everything was okay and not answer the questions. They could do it on their own before they even went into the room. The other thing with the iPads is it was really a game changer for us because we could, the results would flow directly into eRecord. So even when we were doing it on paper, the provider had to then transcribe all the answers into eRecord, which was an extra step. So this kind of streamlined it and made it more efficient. So then we were doing this for a while, but we found that we didn't know how it was working, put it that way. We didn't know if the providers were even looking at the answers to the screen in eRecord or not. Were they documenting that they talked to the patient about it or not? We just didn't know. So we decided to do a little study. We interviewed 20 patients. This was after their pregnancy was all over, who had screened positive. And then we also reviewed their medical chart for documentation, what happened and all that. And frankly, we were kind of surprised at the results. There were I think, 5 patients that answered positive to the self-harm question, which is, are you thinking about harming yourself? And only one of those was it even documented in that visit that the provider talked to the patient about that answer to that question. And that part really shocked me. But there was also, throughout, when we looked at the whole course of the pregnancy, we also found that there were a lot of people that, were referred for, either counseling or maybe a medication consult with our psychiatrist, who's also part of our team. But they either didn't answer the phone when the secretary called them to make the appointment, or they had the appointment and they didn't show up. So we basically realized that screening and referring, while it's helpful, it doesn't even begin to solve the whole problem. So then we're like, oh God, what are we gonna do? So we decided to create a new position actually in our office. And the position is called a behavioral health care collaborative care manager. So a mouthful, but we just call her our behavioral health manager right now. But she's like a care coordinator, but she's also involved in our office, and she's a full-time person. Be a social worker that can do psychotherapy, or it could be a psychotherapist. It does have to be somebody that can kind of do brief interventions and is trained to do that. So anyway, we hired her, and she's on site full-time, and she's available for team visits. She can come in on the fly, and if somebody screens positive at the beginning of pregnancy, she can go in either before or after the OB provider goes in, and she can do a brief assessment, kind of, establish care with the patient, so the patient has somebody they can talk to. She has a direct phone line that they can call her anytime through the office, rather than going through the whole phone system, press 1 for this, 2 for that. She has a voicemail. They can leave her a voicemail if she can't answer the phone right away. She also, I call her the bridge. She's the bridge between finding out somebody needs some attention and getting them to the right place. So she can, make sure they get an appointment in a timely fashion. She can call them in between OB visits. At the beginning of pregnancy, your OB visit is every 4 weeks, and that's a long time to go without, doing anything to help the patient, right? So she makes phone contacts in between those visits to see how the person's doing, until they can get into, either see a therapist or get back to their next visit and check on, like say they got started on medication at that first visit, like they can check in and make sure the patient's not having side effects, so they don't stop the medication without telling us and just, get lost to care. And then the other key thing that she did is she made a registry so people don't fall through the cracks. So she has a list of patients she's following, and she has little check boxes of when she needs to talk to them next, or what needs to happen next. So people don't fall through the cracks. And just, if they don't come to their OB visit, she calls them, So anyway, this was, I think, the key piece to getting the whole picture, and getting everything, kind of running smoothly. The other thing that she does is the standard of care is if somebody has a positive screen, they should be rescreened in 4 weeks to see how they're doing. And so she would push out the screen through the MyChart to the patient, and have them do that screen and follow it and make sure that it happened. And the biggest part of it is doing the team visits. I mean, I think OBGYN, OB especially, is really become a team effort. It's not just the traditional model of OBGYNs doing everything for everybody. They just can't. And a lot of us are not, I mean, we do gynecology, we're surgeons also. So a lot of us have a surgical mentality and we don't have a touchy-feely type of mentality. So it's hard for some providers to even address emotional concerns with their patients. So that's kind of a very, very, very brief overview of what happened over the last 10 years. The other organization that I briefly want to talk to you about is am I okay on time, Paige?
Yes, yeah, you have a couple more minutes to talk about the other work. Yes, please do.
Okay, good. The New York State Perinatal Association is an organization that our members are from all the walks of perinatal care. We have providers, physicians, nurses, midwives, we have doulas, we have social workers, we have community health workers, all are members of our organization. We have lactation consultants. I'm sure I'm leaving somebody out, but and then with the providers, we also, it's not just obstetricians there. We have pediatricians that are members, we have family docs. So it's a wide group of people. We call ourselves the conveners. Our main mission is education. We have an annual conference in Albany in June. This year it's June 10th through 12th. We've added some things to our conference. We've added a pre-con day for Wednesday, where AWON comes and does the training for like postpartum hemorrhage and things like that. And it's an all-day training that you can sign up for. So, which is separate from our conference, but it's the day before in the same place. So we have a 2-day conference, and we convene all these different voices, and we try and encourage. When I'm also on the conference planning committee, so we try and get people from all walks of life giving talks, not just physicians or nurses talking to everybody. Last year we had a doula panel. It was amazing what people were doing. Anna, I want to talk to you after this. See if you would be willing to come and talk to us. Our other educational activities, our webinars, we do quarterly webinars, although we've been a little lax this past year. And then our second objective is advocacy. We advocate for upcoming health bills that are in the state legislature. We sign on to, we write letters to sign on to the legislation. We keep our members informed of the legislation and what happened. 2 years ago, we had the governor come speak to us at our lunch, and she was awesome. So we're very involved. And also at the conference, New York State Department of Health has a very big presence there. Last year, I think they sent 22 people to our conference. So they're there to not only give us updates. We do have 1 or 2 sessions where they give us updates, but they're there to listen to our concerns. And it's a good time to network and meet your people that are in New York, in the Department of Health, so that you know them and they know you, and they learn what you're doing. So it's a great place to get ideas. That's also where I met Sonia, so that's why I'm here. So, I think that's it right now, but I'm going to go into a little more stigma stuff later, but
Thank you, doctor. Thank you so much. And I love where we ended there. When we think about stepped care, I'm going to take it one step further and include advocacy, right? We're providing the services and the treatment based on acuity. And at the same time, we need to be advocating for more. And we're going to talk a little bit before we end today about what's next but really appreciate the organization and encourage people to join. And also, I imagine there's a lot of interest in the collaborative care model, and we'll be providing a lot of information in the chat today and also in follow-up materials. It's such a no-brainer, if I can say, to integrate behavioral health into an obstetric setting. And I'm so glad that we're finally starting to see the value of what I'll call one-stop shopping, right? It's all happening right there. We don't have to ask somebody to go to yet another appointment somewhere else and meet another person. It's happening under one roof. And I'm seeing that with so much of the work that you do. It's community in so many different ways. So thank you for that. And I want to move on to the next question, which many of you have hinted to so far, and that has to do with stigma and how each of you in your work sees the role that stigma plays in interfering with perinatal people accessing support and treatment. And in thinking about that, what are some possible solutions to overcome that stigma? And Sonia, I'm going to start again with you. If you can talk to us a little bit about stigma.
Sure. Thank you. First off, I do want to say it was really difficult not to write in the chat. And to all the panelists, I wanted to say, way to go. It's so exciting to be here because the Resource Center, we act as a bridge as well as we provide services and support. But this is just so exciting. And to be here to break through stigma. I see stigma personally from what I experienced when my sister went through postpartum psychosis. So every single day reminded how unfortunately that feels, because I can still remember the whispers of the emergency room staff going to see my sister there, and people, as maybe Dr. Tortolet expressed, realizing some people don't have the training yet, don't feel comfortable to deal with the emotional side of things. So I see it as 3 different areas, and the importance that we look at these different areas, because especially the maternity, the mortality report, where mental health, unfortunately, with the loss of moms, that those were all deemed as preventable deaths. So looking at the systems level, the community, family support level, as well as the individual level. We collect a lot of quotes from those who attend our groups that they want to share what they are experiencing stigma-wise, and we share some of those with what we see as solutions in each of these areas. One of the main solutions we see is training education. So even beginning with implicit bias training, trauma-informed care training, the Resource Center, the work we do, we come from a health equity, racial health equity lens. So when we're hearing comments that are totally unacceptable, so really looking to advocate for a solution that education within systems wide, because it's very unacceptable what we are hearing. And a lot of families are brushed off. And even a lot of families that I will share here, because looking for solutions and making changes here, that we move from just using the word postpartum. Again, postpartum is not a perinatal mental health condition, it's a time period. And from our experience, it's hurting people. So when somebody might have been hospitalized for postpartum psychosis, but they don't realize that, and they are going around saying, I had postpartum. So when they go to have a subsequent baby, that maybe people are not fully being able to help them and put in a prevention plan for them. The next level, community, family, and friends. Unfortunately, family and friends, they can be great supporters, or in our society, where our society really is not very empathetic and caring in general to mental health conditions to begin with. But when it comes to perinatal mental health, from our experience, it seems even more so that people have very, very high expectations of birthing persons, mothers, fathers. What other society is not our society many times is not recognizing that, okay, somebody, all those weeks, they grew a human. They then maybe sometimes they've had major surgery, major health complications, and family and friends all of a sudden may expect that that person is there to entertain them, or instead of taking on and understanding mental health when it comes to parents, that they may say things when the parent is reaching out for help, because we do encourage parents to reach out for help. And a lot of times we find that the onus is put on that parent to reach out for help. So, but at the same time, people have to be listening. So unfortunately, when family and friends say unhelpful, unkind things of, you aren't going crazy, are you? Or you're not like one of those people, or you don't seem like a person who would go through postpartum complications, postpartum mental health complications. And then on the individual level, unfortunately, the mothers, we come across so hard on themselves. They don't feel good enough. They speak to themselves unkindly, and they feel a lot of times beaten down that people are not really listening to them. So again, solution number one, education, the training. Also, Dr. Tortolot, loved how you shared about the screening. So screening apps or screening on a pad that can increase truthfulness in what they share. Thank you.
Thank you so much, Sonia. And I would be remiss not to add to that and just mention the stigma that we currently have circulating in many ways around taking medication, and the role that misinformation can play, particularly when it comes to pregnant people and postpartum people. What's safe for me to take? And there's a lot of unfortunate mixed messages out there right now that are creating even more anxiety for already anxious perinatal people to have to make these choices that we already know are safe and effective. So thank you for that. And I'm going to move over to Dr. Berry now. If you can talk to us about the role that stigma plays that you see in the work that you're doing.
Absolutely. And thank you so much, Sonia, for setting that up. Stigma is a real big issue in the work that we do in terms of domestic and gender-based violence, and also the combination with perinatal mental health, because it does combine, general mental health and, violence and whatnot. But really this idea of like, what is the perfect motherhood? What's the perfect parent? That does impact not only the individual, but also the systems as well. And so what do we see is this idea of this internalized or individual sense of the fear of being a bad parent. As I mentioned, during pregnancy is usually a time where there's a higher risk of domestic and gender-based violence that happens. And oftentimes it's physical, but we also see an escalation in emotional abuse. And oftentimes the abuser will say, you are going to be a bad parent. You're an unfit parent. You're an unfit mother. Why would you ever talk to anyone? They're going to take your kids away. And so using that as an opportunity for power and control against them. Now, I will say there is sometimes with stigma, there is this fear, but also sometimes this fear is couched in reality. And so there was, a lot of Black and Brown communities where there was intimate partner violence in the household, CPS or ACS would be called. And sometimes those kids were taken away. So there is that reality that I think, we would be remiss without saying that out loud, that has happened. And we as a society need to move away from that and really think about, instead of mandated reporting, think about supportive parenting and supportive reporting as an alternative way for thinking about that. In addition, there's just a lot of shame and isolation. One of the big things that a lot of abusers will use would be to isolate the mom or the parent. and say no one wants to be around you. You're too difficult. And so, even hiding phones or not letting them call anyone else. And so there's a lot of isolation that comes into it too. And on top of a lot of shame that comes into it too, that, I let this happen to me. Who's going to believe me now that my partner, who people like, is causing this type of harm to me? And then there's a lot of minimization of symptoms that we do see. He just says this and that, I can deal with it. I can move on. I can get by with that. And in terms of parenting too, like, this is going to get better. This is always going to get better. Why would I try and introduce any type of outside agencies where this is going to get better? So more isolation, more minimization of symptoms. And then we also have like the social and public stigma too, in terms of just having lack of support or not having people be aware of what's happening in the community or with that individual person, and not knowing how to talk to them about what is going on. And then, of course, cultural barriers that also come into play. There are definitely pauses around culture and religion, but sometimes it could be used as a way to kind of hold people in their place. Why would you leave a situation? Your identity as a mom should be that. And so why would you leave and be an unwed, single parent? And so all these play into it as well. And I also do want to take some time to talk about just, systemic racism and just the distrust of the healthcare community that plays so heavily in our Black and Brown communities. And again, there is a fear, but it's also couched in reality. I'm sure many of you have seen that TikTok video or Instagram video of this mom in Texas who was in labor, active labor, and I have kids too, and I remember being in labor, and it's very, very painful. Her shouts and screams for help and saying, "I'm giving birth right now," were ignored. On top of that, what was also striking me when I was watching the video is that her mom was recording this happening. So also thinking about, that intergenerational trauma of the mom saying, I'm going to bring you here to get help, and yet my daughter is not being helped. And now my grandchild is also not being helped too. And so, of course, if that's your reality, you're going to have a distrust of the system. And that's just giving birth. Thinking about the idea of I'm depressed or anxious or have trauma, like, you're going to be dismissed as what has been infiltrated into the lives of BIPOC communities. And so that also perpetuates stigma and perpetuates this lack of distrust within a healthcare system as well. And then, of course, there's these, as Sonia mentioned, like some of our healthcare professionals, again, that nurse who was doing the intake, had a lot, I don't know what's going on, so I'm not going to try and explain it, but really the lack of knowledge of what it means to understand the historical trauma that you're causing this person, and being aware of that there is stigma that's already happening. And the fact that she came to you for support and dismissing it is further traumatizing her. And then, of course, because that video went viral, now we have thousands of people who are now also going to be feeding into this concern as well. So there's a lot going on already, historically and currently, individually and structurally, that really kind of escalate this stigma that we're talking about, which is really lack of awareness and knowledge and education. And so a multi-level support and approach is really going to have to take everything, all of this into account in order to really truly make a dent in getting people the care that they need. And so we need like structural solutions, which requires screening, of course. I think it's so crucial so no one falls through the cracks. Usually it's like the squeaky wheel gets the grease, right? But there are many families, and we know with postpartum mood and anxiety disorder, sometimes it's a quiet person who's struggling but not saying anything. Those are the ones who I worry about a little bit more. And we're not going to identify them if we don't screen appropriately. And then not only with screening, you also have to have, access to care. And so making sure that when you screen, you also have the equity of making sure people get access to the care and support that they need to be able to do that. And so there are all their programs that allow for that co-location and the collaborative care model that Dr. Tola mentioned, but also there are other types of co-located integrated care that can also help depending on which system that you're in. And then the other big thing is, provider knowledge and education, using destigmatizing language as much as possible, recognizing that, when you think about, health, that mental health is included in that. That is another vital sign. When you're taking somebody's blood pressure, you should also be thinking about taking stock of their mood at the same time, or their pain scales. And part of that's just destigmatizing. This is what healthcare is. We talk about your blood pressure, we talk about your pain, we talk about your mood. I think that really, really help the providers also equate the two, but also help the patients equate the two as well. And then, of course, we just need to do a lot more messaging and awareness. I love that we're doing this here, but also, using social media. As again, you saw that video that went viral. Can we have a video that goes viral about mental health is so important as well? And really kind of making sure that everyone understands that, that this is so vital and that we can actually make a difference.
Thank you for that, Dr. Barry, and such a wealth of information you just shared with us. And one thing I just want to highlight, you had mentioned that quiet person. And what we know so often, when we think of that statistic of 75 to 80% of all people who are experiencing a PMAD go undiagnosed and untreated, a lot of times it has to do with staying quiet. And so much of that has to do with stigma. And certainly in my work for so many years with pregnant and postpartum people experiencing mental illness, it's either the quiet person or it's the person who appears to be okay. That person who walks into your office and has their hair done and makeup on and looks great, and you think to yourself, wow, she looks really good. And she might just be the illest person that walked into your office that day. And I say this because we cannot in this space judge a book by its cover. We cannot just look at somebody and decide that they're okay and they're not struggling. And it's why all the work that we're talking about here today, especially as it pertains to stigma, is so important. We have to ask the question and we can't make assumptions. So thank you for that. And Anna, would love to turn over to you now and hear you speak to the role that stigma plays, particularly in your community.
I first just want to say that that was just so eloquently spoken, Dr. Berry. I feel like you covered so many important pieces to stigma, especially the root causes. And being in an Indigenous community that a lot of your services are outsourced in, we see so many of the things that Dr. Berry mentioned. And I think one of the biggest parts that plays into the stigma here is trauma. And that could be intergenerational trauma from colonization or the systemic barriers that they see and the disparities they see in the medical system, or that could look like an experience that they had with a provider that made them not feel comfortable and just kind of refrain from being seen at all. Um, I also think that being in a community that is so close knit and an actual community that it makes it a little harder um, for stigmas to die down. I think that mental health is one of the biggest stigmas that we experience here. It's really a taboo. You don't talk about it. There's little to no resources. We do suffer from high substance abuse rates, and we have a therapist, but that is maybe one time a week if you're able. We do have specialists who do come here on site and offer their services, but it's only maybe one time a month, or like I said, that one time a week. Um, there is really no resource directory or database of BIPOC providers here in the area that are not making people feel not making people feel comfortable or as if they have walked into a safe space or as if the safe space is going to remain confidential or that they are going to meet them where they're at and actually offer them the resources and solutions rather than just kind of sticking a label on them. Um, I I really I also feel that when there are different like support groups and things like that, it kind of refrains people from coming out and sharing how they really do feel and being in a vulnerable space in front of their community. Um, just, for the reasons of taboo and not speaking about it and not being educated on all of the different aspects of mental health. And again, being able to provide the solutions and bridging that gap of having these experiences and where are the referrals and where do you go from here and how do you make sure someone is seen all the way through until they are equipped with everything that they need. I think that is such an important aspect. And like I had mentioned earlier, I did a maternal health assessment survey here just to kind of gauge where my community was at. And a lot of people reported that they just felt that their visits with their doctors, their maternal health providers, they were okay, but they were impersonal. They didn't feel like they really met them where they were or understood them, or it was just, another patient that they were seeing for the day. And I think that providers being able to create safe spaces that make people feel comfortable and that are personable, it would kind of open up a plethora of opportunities for them to provide the solutions, or to, if they can't provide the solutions, then where can you refer me to that I'm able to get the help that I need? Um, and yeah, I think that stigma is really based in access, and that looks like access to education. Most importantly, I think that we can destigmatize a lot of things if we had proper education on certain matters. And I also think that Indigenous people, like I had also mentioned earlier, are very underrepresented in a lot of spaces. And so to sit here on a panel today and be invited at this table is just an amazing thing. But there are so many times and so many spaces that we're not afforded that opportunity, and we're kind of just left out. So what does destigmatizing stigma look like for Indigenous communities if we're not actually included in the conversations and the discussions? And having platforms that really speak to that. Um, yeah, thank you.
So well said, Anna. Thank you so much for that.
Absolutely.
I want to turn over to you, Darian, and get your perspective on stigma.
Of course, thank you. And thank you to everyone else who has already spoken. A lot of what I had jotted down while everyone was speaking is very complimentary to what has already been said. So thank you. I guess based off of some of the community members that I interact with during our support groups and why they choose to come to support groups and how scared they are with even reaching out and attending, or their fears that have prevented them from seeking help in the first place, um, was really rooted in that lack of education, was rooted in fear of judgment from their families mostly, fear of judgment from their peers, fear of judgment from um, their healthcare providers, comparing themselves to other moms they see on social media and seeing that I don't look like this mom. I just gave birth 2 months ago and I'm not happy. I cry every day. That's not normal. Um, and so it's fear of speaking out and seeing themselves as I'm not a good parent for experiencing what I'm experiencing. Um, so the lack of education, perinatal people think that they're alone in their struggle and in their experience, and fear that others won't understand them or label them as unstable or unfit. Um, and with sharing their feelings, especially to their family, a lot of them had fears of even expressing to their partners, to their siblings, to their parents, um, because of that judgment. And then a lot of that fear is also rooted in the historical implications with children being taken away, especially from our Black and Brown communities, legal consequences specifically happening in those communities. So that also plays a very large role. The lack of access to supportive, non-punitive treatments and treatment programs that are specifically designed for perinatal people. And with a historical, like racial lens, anti-racist lens, trauma-informed lens. So some of the solutions, and also similar to what has already been said, is educating healthcare providers and OBGYNs, especially since they're the ones seeing and interacting the most with our perinatal patients. A lot of them don't have training in a lot of those histories and experiences of medical violence, especially towards Black, Brown, Indigenous, Hispanic communities as well. And it's very surprising that that's not a part of their curriculum, or they need outside training. This is not about implicit bias training. This is not about just informed or trauma-informed care trainings. This is beyond that. We need collaborations. We need to talk more with each other. We need to have more of a multi-level, multifaceted way that we are communicating at a systems level with each other, at an institutional level with each other, to combat these statistics. These conversations we've been having for more than 10 years, and the statistics are only getting worse. Education is one of the biggest pieces here. Let me see what else I had written down. Creating safety protocols in-house. So these involve creating and collaborating with crisis hotlines, maternal mental health hotlines, other community supports, instead of directly reaching out to 911, instead of directly reaching out to CPS. There has to be other protocols in place that our community health workers, our social workers, other community members are feeling supported and feel trust in us, that they can come to us and talk about how they're feeling. So creating those protocols in-house at our institutions, CBOs, in collaboration with others, that 911 and other punitive outlets aren't the number one go-to. And then I guess a third solution is just continuing sharing and accessing programs, putting these programs in people's hands, resource lists, directories, like Sonia had mentioned, and many others on the panel, arming our community members with resources, because that's only going to save their lives. I'm sure I'm forgetting others, but I'll continue adding on to that probably with the next question. So thank you.
Thank you, Darian. And I was really, as you were speaking, thinking to myself how grateful I am that in the latest maternal mortality report that was put out by New York State, that several of those very things that you are mentioning are included in that report.
Yeah.
So really grateful that those things were touched upon. So thank you so much. And Dr. Turlo, I'm going to turn to you now. I would just ask you if you can get a little bit closer to the microphone.
Okay.
And would love to hear your perspectives on stigma in your work.
So I'm all about screening, so I'm going to start with that. So when we first started this whole thing, even just when we were doing postpartum screening, the physician or the provider, nurse practitioner, whoever, midwife, whoever it was, would just ask the questions or give the patient the piece of paper in the room for them to answer the questions. So it was up to the provider to decide who got the questions, right? So now we changed that. The screening has to be for everybody. So now they're given when we moved to paper and tablets, they were we first started with, they were given the paper by the check-in desk for any new OB visit, for any postpartum visit, and then now we've extended it to the 28-week visit. So our check-in staff had to be, trained to do this because they had to know where the patient was in their pregnancy to do it, right? And we have little things in e-record now that like a little green red dot when they need the screen given, so that when they check in that they don't have to think too hard about it. But just moving from kind of targeted screen to universal screen was a huge lift in our practice, because it involves the whole office, not just the provider. And the other thing was when patients perceive that they're being targeted because they might be a specific race or a specific, insurance type. And we take all insurance types in our practice. We're about 50% Medicaid. But if people feel like they're being targeted because maybe they're on Medicaid or if they're Black or brown or whatever, we found that those patients were asking a lot of questions like, well, why are you giving me this screen? And so now we can normalize it and say, well, we give this to everybody. We ask everybody these questions. It's just part of your healthcare. It's not separate or over here, And so that I really do want to kind of really make that point because it all starts with screening. So normalizing screening. And then normalizing screening also brings up conversations. Like if a patient asks, well, why are you doing this? And we do it for everybody, it's part of your healthcare. It just opens up the conversation. Like if your provider's willing to talk about it, you're like, wow, So it's a powerful message, and it develops trust between the providers and the patients. I do want to reiterate what you said, Jaren, about fear of stigma and fear of asking for help, because you might be worried about what your partner thinks or what your family thinks about asking for help, or what your coworkers might think, or your job. What if my boss finds out about this? What if Child Protective finds out, is my child getting taken care of? It's such a fear of asking for help. And I've seen situations where people don't ask for help before we were screening everybody. And they were so depressed or so anxious, or, their bipolar was getting worse or whatever, that they couldn't even do their job. And then they got fired because they couldn't do their job. Whereas if we recognized it and talked with them about it and took them out on disability so they had time to, get treated and get stable again, they might not have lost their job. So it's a huge issue. So those were kind of the 2 points I really want to make. But then the third point I want to make is providers. Providers can actually stigmatize patients by not slowing down and trying to understand what's going on. And I'm going to give my blood pressure medicine example. So people that are on blood pressure medications during pregnancy for high blood pressure, sometimes they're not taking them. And so then, we have to say, you got to take your medicine, blah, blah, blah. You almost like we're giving them a lecture. When I first started this whole OBGYN career 35 years ago. But you got to figure out why, right? And if they're so depressed or so anxious that they can't go to the pharmacy and pick up their medication, or they can't remember to take it because their concentration is bad, or they just can't get out of bed and do anything, you have to be able to have a complete change of direction from the initial reason for the visit. The initial reason is, okay, I need I need the heartbeat listened to, I need my blood pressure taken, I need but the real but that might not be what needs to happen at that visit. And the provider needs to be able to pivot and talk about why. So it's educating our residents, our nurse practitioner students. We have a lot of people come through for their OB rotation on their nurse practitioner rotations to, while they're learning. We have a lot of learners in our, we have midwife learners. A lot of people come through us, but to get them to recognize that they have to sit back and just listen, like not lecture a person, is kind of my pet peeve. So, and then, you know, if the patient walks out the door and they just got lectured but the real problem wasn't addressed, they feel dismissed and ignored, and they're not going to come back, and they're not going to form a trust with you because, you know, you didn't take time to kind of figure out what was happening. So those were kind of my main points.
Wonderful. Thank you so much for that, Turlo and Dr. Turlo. And one of the things that really stood out to me, that all did, but one in particular, is asking why. It's such an important question to help us better understand the client or the patient in front of us. What are the obstacles? What are the barriers? What's going on with you above and beyond the intent of what this visit was meant to be? Let's understand why. So thank you all for your really informative responses. We're having such a rich dialogue today. I lost track of time, and just being mindful of the time. We have one question left, and it's an important question. And to ensure that we have enough time to get to some of our audience questions, I want to ask us to do a bit of a lightning round. I know that I had asked earlier before, in preparation for this, that you have a certain amount of time, but in honor of the time that we have left, I'm going to ask you to kind of take an abridged response to this last question that we have. We've covered so many bases today and last week as well regarding resources and services that are currently available with people struggling with perinatal mental health conditions. And the question that I want to pose to you now is, what do we need moving forward to improve outcomes around perinatal mental health and access to support and treatment from your perspective? If you had a magic wand, where do we go from here? What do we need? And Dr. Berry, I'm going to start with you on this one. Sorry to put you on the spot.
No worries. I'll try to make this quick because I think about this a lot. But if I had a magic wand, it would probably be three things I would focus on. One of them we already touched upon, so I'm not going to elaborate too much upon, but it's really like integrated care and co-located care, which I really do think will reduce stigma, help with universal screening, help with triage to the next person. I think that would be really, really helpful. Number two is something we do a lot in our program, which is really thinking about capacity building and workforce development. And as we alluded to, many of our providers may not know what it means to actually screen appropriately, how to talk appropriately, understand the historical context of why people may be fearful of coming to see someone. And so really thinking about how do we build up that workforce for everyone in a multidisciplinary manner. So it's not just the psychiatrists, it's not just the OBs, but also thinking about the social workers, the psychologists, the doulas, the midwives, everyone in that continuum should be trained effectively, and we should uplift all the knowledge that we're taking in together. And in particular, not only just perinatal mood and anxiety disorders, but also really thinking about that next step, investing in the infant parent dyad, that early childhood mental health piece. Because again, part of why we're doing this work and talking about perinatal mood and anxiety disorders is because it's effect on children, and it starts during pregnancy. And so really thinking about that continuum in terms of that learning and knowledge base. And then lastly, just really thinking about addressing violence and trauma is sometimes is the root driver for a lot of what we're seeing in the system, in the perinatal mood system. And so not only doing universal screening for mood and anxiety disorders, we're also doing universal screening for trauma and also just PTSD. And not just thinking about trauma with a capital T, but how can discrimination also impact that? And then really making sure that we reduce stigma in terms of asking for support, moving from mandated reporting to supportive parenting and supportive reporting as well.
Thank you, Dr. Berry. I'm going to throw it over to you, Sonia. What is your magic wand?
Sure. It's a long list. I want to say thank you to all the panelists sharing what from their experiences and everything. I do want to say thank you, Darian, for what you also expressed in the last question too. So my magic wand would include, yes, moving beyond basic training here I think it's very important that everybody recognizes what their role is in the parental mental health safety net. Number one, everybody realizes they have a role to play. So it's recognizing you have that role and getting the education, getting equipped. Number two, we have this wonderful roadmap now through New York State. So looking to implement, working together, collaborations, the Resource Center, we have Project 62, our vision. So everybody working together to implement those recommendations. So we are actually having progress here in different areas that is so much needed because lastly, this shouldn't be left up to, again, these perinatal people really working so hard. They are working so hard as their life totally matters. And the importance, as I'm wrapping up here, that all of us recognize authentic suffering and putting into cultural, recognizing cultural practices all the way back the 1980s, the anthropologists Stern and Krugman, the work of Sally Plaxton with Mothering the Mother, Ellie Taylor, Becoming Us, Jane Honigman, Postpartum is Forever. So there is a lot of work out there, and I look forward to everybody working together, moving forward. Thank you.
Thank you, Sonia. And what about you, Anna?
I think both ladies pretty much covered those areas that I was thinking about. But as it speaks to Shinnecock a little more specifically, I as I had mentioned throughout this panel, I believe that community is so important. And we're such a close-knit community here. Everyone knows everyone. Um, and I think that it's important to reconnect with one another and then also kind of reestablishing this I heard this term before, the casserole community. Um, I've always noticed that when a person passes away here in our community, we all come together and we bring them meals and we support them and we shower them with love and compassion. And I would love to see that happen through every part of an individual's life. Um, I think that it would be amazing to have medical care, healthcare systems, healthcare providers that feel like a part of your community. And like I had also mentioned, I think it's so important to bring the Indigenous voices into these spaces and allow them to share their experiences. I know that it's so similar to what our Black relatives go through and our other brown relatives go through. And we kind of intertwine and connect in so many different ways because of the traumas that we've experienced. Um, I would love to see more training for providers, specifically for the BIPOC communities. I think that's so important. And like I had mentioned, you go to the doctor's office, it feels impersonal. You want to have your education, you want to have your resources. If you feel that maybe they're not giving you what you're looking for, you want to be able to offer support to another person in the community who maybe is experiencing the same thing as you. And how can you be a good relative to them and offer them either the support that they need as a peer or a resource or a referral to someone that can provide what they need. Um, I there's just so much I could say about this subject, but I think that just really returning and reestablishing and reconnecting to one another and community rather than just these so um, modernized and systems that kind of just take away the energy of not only being community but individualism. Everyone has their own path and their own pathway, and it would just be nice to see everyone just come back to the root and reconnect to community. And I feel like there would be so much more insights that are gathered and more solutions that we would be able to provide as a collective rather than individually or under these systems that are not built with inclusion in mind.
Beautifully said, Anna. Darian, how about you?
Yes, I'm going to try to go through this fast. I have a couple here that I have. The first one is receiving support from people who look like us. So allowing perinatal people to create their villages um, with those who look like them, have similar cultural experiences. One example that comes to my mind is Sonia's Empower group, I believe it's called. Or please correct me if I'm wrong. But it's yeah,
It's Emerge.
Emerge.
Emerge. Yep.
Thank you. The Emerge group for Black moms. And it's such a beautiful space where Black moms who are experiencing the same experiences with perinatal, mood anxiety disorders, other mental health challenges, just to say, a few things. But it's beautiful spaces where people of similar cultural backgrounds can lean on each other and create community with. And we need more of those. Normalizing mental health in general with our families, our community organizations, healthcare settings, by talking about it more. So more educational workshops, sharing our experiences, having just spaces where we just talk about our experiences with mental health, talking about how we got help, um, our therapy journeys, just sharing about what our mental health journey was. I'm over here in this space and I'm squeezing my stress ball. And just in talking about different coping mechanisms and, being in community with people who are, managing the same things, this is what makes it normal, speaking about our experiences. So making it more comfortable to talk about these things, um, builds trust ultimately in our communities. Um, Another one is blasting to all of our networks and creating new partnerships amongst ourselves and one another to connect our community members to workshops, community events, trainings that can be for staff and community members. So community members can also arm themselves with knowledge, become lactation counselors, and all of these other things that we've talked about today. Um, Another solution is just continuous screenings, not just once, not twice, but continuously screening our moms throughout their pregnancy and postpartum journey, to catch any snags that we may not have found earlier on or may have come up later on. And then ultimately putting emergency resources in everyone's hands, not just those who are experiencing mental health challenges or perinatal and mood anxiety disorders, but everyone who is pregnant. So then um, everyone has equal access. It's equitable to everyone, and everyone is ready just in case any crisis comes up. So those are the few that I can share right now.
Thank you, Darren. I'm already decided that you're all in charge. These are excellent solutions to help us improve perinatal mental health outcomes. And Dr. Turlo, last but not least, what would you do with your magic wand?
So I'm not going to repeat all the things I was going to say because everybody else covered most of it. But from a physician point of view, in our New York State Perinatal Association retreat in October, we heard from our midwife partners, and I found out that they've decreased the number of training spots in New York State for both nurse practitioners, for both midwives and for nurse practitioners that are learning how to be psychiatric nurse practitioners. I mean, if we're trying to, correct the maternal mortality, which is at 22% of mortality is caused by psychiatric and substance use issues, we need psychiatric providers. We also need to increase the number of people who prescribe for opiate use disorder. We have to increase our training for our OB residents and our OB nurse practitioner students and our midwife students in our office so that they know how to safely prescribe for our OB providers, how they can safely prescribe for certain things. There's not enough prescribers, even for, anxiety and depression. And then one other thing is I just want to mention that I feel like COVID was the equalizer. We need to continue telemedicine appointments. We can't let the government say we can't do it or the insurance companies won't pay for it. We really need these visits. It can, in a way, it decreases stigma, but it also makes it easier for patients to get to their visits. They don't have to take time off work to get to an appointment. If you have to drive there, do an hour-long appointment and then drive back to your work, that's at least 2 hours that you had to take time off work. And a lot of people have to use their vacation time for these kinds of things. Some people have transportation issues, childcare issues. So, I mean, telemedicine has been amazing. You can even, if you're too far away, there's no provider near you, you can be with a provider that's, in Syracuse or, 2 hours away, by telemedicine. So, and just my last message is just to show up for your patients. Just show up and be there and listen. Be present in the moment. Don't be trying to rush through the appointment because you got to get to somebody else. And then come to our conference for NISPA in June 10th through 12th. You can hear from all these other people about what's working, what's not working,
Thank you, Dr. Turlo, and thank you all for providing such valuable perspectives on perinatal mental health and stigma today. Before we move over into our Q&A section, I just wanted to share our first poll results. So, David, if you can go ahead and pull those up really quickly. And it looks like our audience, as it was last week, is primarily social workers. Hey, social workers in the house. We also have nurse midwives and we have psychologists and many other disciplines that are represented. So it's wonderful to see such a diversity of disciplines. And I am also going to ask that you just participate in one last poll question, which David will put up for you. And this is your likelihood of applying what you've learned here today. So please take a minute to respond to this as well. And I will announce those results before we end for today. But what I'd like to do now is to move over to our questions. And I want to start with this, and I'm going to throw it out to the entire group. Dr. Barry, you had shared a TikTok video that had gone viral of a Black woman giving birth at a hospital in Dallas, Texas. There have been other also posts this week and other times that have shown similar tragic situations. And given the stark disparities in Black maternal mortality and the systemic neglect illustrated in these cases and others, what concrete actions should healthcare institutions, policymakers, and clinicians take to dismantle these patterns of bias and build a truly equitable maternal care system? And I really open this up to all of you to respond.
Yeah, absolutely. And I definitely open up to the rest of my panelists to respond as well, because they have a lot of great ideas. And this is an excellent question. So yes, I mean, the fact that there were 2 videos that went out this week is really sad and astonishing. And also, one of the things we talked about is the value of telehealth and just technology. But technology has now really allowed us to be able to unearth a lot of what's happened before. So if you can imagine these two videos that went out, you can just imagine that there are probably hundreds of videos and other opportunities or other times this happened that just weren't captured by video too. So there really is a huge need for us to really address what we understand to be some of the drivers and root causes of Black maternal mortality as well. And one of the things, people often talk about social determinants of health. One of the things I actually really also, again, when you think about root causes, is thinking about the political determinants of health. Like, what were some of those policies that were in place that allowed us to get to this place where, so many of our Black moms and BIPOC families are often marginalized in terms of just access to care. We can talk about redlining and how there's certain communities which have been redlined, and those communities are the ones where there's been disinvestment in those communities, and those are communities which there's not many healthcare providers. There's food deserts, there's high rates of SUD and overdose deaths, there's high rates of homelessness. And those are policies that were put in place. And even before that, Anna talked about just like colonialization, and then we also talk about slavery. We also talk about Jim Crow laws. There's just a lot of, the Trail of Tears, for that matter, too. There's just a lot of this historical events that have happened that have gotten us to where we are. And so the question is a great question. And what I also like about this question is that it didn't only locate it in one department. You didn't just say healthcare institutions. You said healthcare institutions, policymakers, and clinicians. And so, again, when we think about solutions, we really need to take it like it should be everyone's problem that we need to address. And there's a lot of research that shows that if we uplift marginalized communities, it actually uplifts the health of everyone. We saw this in cancer screening. When cancer, especially breast cancer, a lot of Black and brown communities had higher rates of not being misdiagnosed from cancer. And then when they actually did more universal screening of cancer, they were able to uplift everyone. So everyone was able to be had higher rates of detection. So again, how we can think about this issue should be everyone's solution. Now, what should that solution look like? I think it really requires, again, a really deep dive and really think about policies that can come into place. And one of the things I didn't mention during my magic wand would be actually to think about structural changes and infrastructural changes. Can we think about, uplifting families out of poverty by really thinking about giving people money? We do know research shows that when you provide monetary value to families and don't have any stipulations, it lifts the whole family out of poverty. And that allows them to be able to address some of the other challenges that are in place too. But also really think about education, as we've highlighted as well, and not just education in terms of go to class and read a book, but really thinking about the supervision and ongoing acknowledgement that your presence in every single encounter needs to be evaluated. Could I have done this better? Could I have done a little bit differently, looked at it a little bit differently? And so I don't have any concrete examples. That was what you've asked for, but really just really everyone needs to come to the table, and there's probably multiple different layers and avenues that we really need to address. But I would really welcome other people to highlight and share.
Thank you, Dr. Berry. Dr. Turtello, yes.
I just have one comment about that. In our OBGYN residency program now, we have one of our psychology therapists. They go in with the residents for a certain number of exams, or not exams, but office visits, and just sit in the background and see how the whole encounter went. And then they give the resident feedback afterwards about like what they could have done better or not. And it's a little intimidating for them at first, but it's really been amazing how the residents respond to that. It's being present, listening, not talking over the patient, or those kinds of things.
Thank you. Anybody else want to respond to that? Yes, go ahead, Sonia.
As Dr. Berry shared, like having everybody involved, so everybody part of the safety net. So really looking to equip everybody, and I'd really love to see every single person is a champion for mom's mental health, dad's mental health, perinatal mental health. So really looking here to foster champions. But when it comes to the BIPOC community, as has been mentioned here, really making sure that we are all committed and make a priority to give it, especially in the peer support area that I'll speak to, everybody to have that safe space coming together where people have said to us, thank you, we want to see people who look like us, people who can come together. So everything from our Emerge program or helping different people. And it was such an honor to work with Anna and the Shinnecock Indian Nation. I think the Resource Center, Anna, we learned more from you than the information and training that we provided to you. So thank you.
Thank you. And I'm going to try to squeeze maybe one or two more questions in. This might be kind of a quick one. And Sonia, I'm going to throw this to you, but also welcome everybody else to respond. Are any of these programs and services available outside of the New York City area, or are there similar programs in other parts of the state?
I wasn't sure which particular programs.
I don't know that we know particularly, but I was kind of throwing this to you because of the directory and because Postpartum Resource Center is such a wonderful clearinghouse for any and all services and programs throughout New York.
Okay, so I'm not sure with this particular question if you're asking everything from the intensive inpatient program to the day treatment programs or support groups, helplines, things like that. But our goal with the Postpartum Resource Center of New York and Project 62 is to have that really strong safety net in every single county, where we do want to make sure that all these support programs are appropriately available on the community level or as well as like regionally. So I hope that helps. Any further questions, please feel free to reach out to us. I'll further help answer that question.
Thank you. I'm going to ask a question with my own bias here because I've been doing a lot of work clinically in this area as well, but I'm going to pose this to all of you. Is there father postpartum? I know at least one new dad who became unusually depressed and anxious after his son was born. He needed medication, something that had never happened to him before. What are all of your thoughts on fathers and partners and perinatal mood and anxiety disorders?
It's real. It's real. And also, I think we need to enable fathers to recognize signs and symptoms in their partner, birthing person, whoever, so that sometimes they can be the ones that bring attention to it to the OB provider. So that's why the ROSE program, we encourage partners to come to those. We do the ROSE program in our office, by the way, and we encourage fathers to join in with their partner because it's a series of 4 sessions that gives a lot of information about postpartum depression and anxiety.
Thank you. I saw others wanted to respond, so go for it. Yeah, Sonia, go ahead.
Just quickly, yes, absolutely, as we know from Roundtable 1, but we know with research in New York State, at least 13% of fathers will experience depression, anxiety related to bringing a baby on board. So we are always looking to advocate to include partners, dads, and some examples. The Resource Center, we offer free virtual dad support groups as well as dads on call, telephone support. Also, Buffalo Perinatal has a wonderful dad support program. Other perinatal networks have included dads too, as well as there is a program called Dad Care that has been created by a former OBGYN, a retired OBGYN. And so very important next steps also here to include partners.
And Dr. Berry, I saw you coming to speak.
No, other than just to nod emphatically that yes, fathers do also experience postpartum depression and mood anxiety disorders. And honestly, just to really harness the fact that in terms of just stigma, they also will probably face additional stigma in terms of being reluctant to seek help because it's not really well known that this is an issue. So the fact that story you share where he did seek help and got help is really quite exquisite. And then secondly, what we do know with just treatment and prevention and interventions for postpartum mood anxiety disorders is that it takes the community, on a related, it does take a community. And so making sure that there's enough social support for both parents to be able to get the help that they need. Because they do, oftentimes people become insular and rely on themselves, but really kind of expanding it to rely on other community to help the whole family.
Thank you, Dr. Berry. And I'm going to try to squeeze one more in, again, maybe a lightning round. There's a question here and a vital question. And if we had another hour or another 2 days, we would have also touched on this a bit more heavily. And it's that intersection between perinatal and substance use disorder. And a question from someone in the audience who is looking for resources to support pregnant and postpartum families who are also experiencing substance use disorder. And I'm wondering if those of you who have some resources and programs handy that you want to share with the group, please, now would be a great time to do so.
At Strong Memorial Hospital in Rochester, we do have housed in the psychiatry department a clinic for that. And it's anybody. You don't have to be pregnant or postpartum, but our pregnant and postpartum patients do get priority to get in, because obviously it's time sensitive. So.
Yeah, I'll also highlight there are three that come to mind. One is Dr. Leah Habersham, who works at Mount Sinai, who's definitely given talks as well as in TTAC. She's an OBGYN and has her own clinic within Mount Sinai that really works with parents who have SUD and particularly opioid use disorders. And the cool thing she does is that, once they've delivered, she doesn't end treatment there. She continues working with them after pregnancy. And so that's one program. The second one is Odyssey House, which has different locations and has a residential program here in New York City that does provide resources for parents and moms who have substance use history and provides like a residential space. Because the other thing that we also need to think about with SUD and other mental health disorders is just access to housing can be a real issue too. And so they provide some of those concrete supports for them too. And it's a really great space. I visited last 6 months ago. They even have an early childhood care unit as well. That's just beautifully lovely space. And especially in New York City where space is a premium, it's wonderful space there. And then third, at health and hospitals scattered throughout the different hospital systems, there's a program called the Bridge Clinic or the Bridge program. That works closely, that use peer navigators to help bridge people to resources and to the OB/GYN department, a women's health department at health and hospitals.
Thank you for that, Dr. Berry. Yes, Darian, go ahead.
Yes, I would just like to add, part of our screening process here at PHS for the IMPACTS program, we also ask a question related to substance use and other intense experiences of mental health. And one of a few of our resources that came to my mind, part of our resource directory was Sukasa, residential treatment program, which is really a leading holistic residential addiction treatment program or substance use program in New York State. And I'm also going to provide the link in the chat for those who want to learn more since we are short on time, but I did want to share that.
Thank you so much. And just such an incredible thank you. But before I get to that, in an effort to close down this amazing conversation we've had, I just want to ask David if you can really quickly pull up our poll results. And it's wonderful to see that an astounding majority of you are going to be able to apply what you've learned here today from our esteemed panelists to the work that you do. That's really the intent of both of these roundtables, is to ensure that you're able to take something back or many things back that you can implement in your own settings. I just want to thank everybody for being here today. I want to thank you to our panelists for such a valuable and lively discussion. I want to thank our audience for their commitment to learning how to better serve pregnant and postpartum people experiencing perinatal mental health conditions. And I want to thank you to the New York State Office of Mental Health for recognizing the necessity to cover this important topic and make today possible. And I know we're going to end on one or two slides before we close out for today. And just want to attention everyone to view this special issue of behavioral health news that's also supporting this two-part roundtable. There are several articles that were submitted on supporting maternal mental health and reducing stigma. And also want to encourage everybody to visit the New York State Office of Mental Health Maternal Mental Health Resources page, where you can gather more information about many of the services we learned about here today and more. Thank you all. Oh, and sorry, finally, you can find the recordings for both last week and this week by visiting Behavioral Health News and the link that you're seeing on your screen. You can also actually have access to the decks and the speaker bios as well. So in closing, I want to thank everyone for being here. I really appreciate your time and effort, and I hope that you all have a wonderful rest of your day. Thank you.
Thank you all.
Thank you.